Well, welcome everyone. Thank you for coming. For those of you that don't know me, I'm Diana Boyd. I'm the Vice President of Operations in CNO. As you know, we always start our meetings with an eye care standard. So we're going to start with E for excellence, support a blame-free environment, work collaboratively with a positive attitude, take pride in my work, going above and beyond the minimum. Anyone have any examples of excellence in the last quarter or 6 months or so that they've witnessed or participated in, or anything that they would care to share? Any feedback from patients? Anything that comes to mind now that everybody's got their mouth full?
I got one. I was off for the last 2-3 months, and everybody just kind of had to take up my patients and do the paperwork, and I haven't heard any complaints other than some joking around about it. So.
Well, good. Thank you. Thank you for sharing. Quality pillar. We have received our Midas Plus Platinum Award 4 out of the last 5 years. So that's wonderful. And this is based on utilization and clinical efficacy. So it's length of stay, mortality, readmission rates, stroke and VTE bundle compliance. We've had a lot of surveyors in the last quarter, as many of you have probably been participating with. DNB came. They come annually for a Medicare survey. Maternity was surveyed by ODH. I think that was in April, I believe. Late March, early April? Late March, maybe. And they're a triennial survey, so hopefully OB won't see them for another 3 years, which will make them happy. And then CARF. CARF did a really nice job, or CARF Rehab did. They applied for CARF certification, which is 1,400 standards that the staff had to come up with answers and develop a process to show the surveyors that they comply with those. And they received 3-year CARF certification, so kudos out to our rehab staff and all those that participated in that. And then DNB was back for our primary stroke center certification. So that was just in April as well. So we've had a lot of people poking and prodding in the last quarter. Leapfrog, which most of you may or may not know, was designed many years ago by a group of corporations or businesses that wanted to look at the quality and the safety that their employees were receiving as patients. So they started rating hospitals on a bunch of different factors, some mortality or some mortality factors, some OB factors. You know, if you have a closed ICU, meaning only the intensivist can admit. So there are some things that they look at that we don't even do. All the information they get on us is publicly reported. It's nothing that we supply them. So I did talk to Carol a little bit because I've always been an A and we wondered why we dropped to a B. The data in Leapfrog is probably 18 months to 2 years behind, and our C. diff rates and our CAUTIs were a little high right then. So she thinks that that's probably why we dropped from an A to a B. We would like to get that back up to an A. Bruce has shared that probably 40% of the hospitals in Ohio are an A score. So we would like to be back up there with them. So we have made some strides in our C. diff and our CAUTIs, so hopefully that'll come back up. Our hospital-acquired infections, talking about CAUTIs and C. diff. We did have 2 in the first quarter of 16, although CAUTIs and C. diffs have dropped probably 50% the last couple of years. So we are bringing them down. It still requires a lot of consistent effort. Central line infections, we've had 0 of those in the last 3 quarters. This one has actually broadened. It used to be just surveyed in the ICUs, but a year or so ago it expanded to the whole house. So anybody that has a central line, PICS or anything that get infected now count in this number. Our C. diffs, we had 2 in the first quarter. This is still a work in progress. A lot of hand washing, a lot of Clorox, a lot of work with housekeeping and anyone that goes in patient rooms or takes care of those population. Healthcare acquired pneumonia. This one is still kind of on the higher end in my mind. We've instituted some mouth care protocols within the last year or so with SAGE, trying to make some efforts to keep patients that are in the hospital doing mouth care every 4 hours. We've just had some repeated education on that, but that's something that we're still seeing quite a bit of. The MRSA have not had any of those in the last 3 quarters. Surgical site infections is another thing that we have been working diligently on. Their scoring methodology has changed over the last couple of years too. They have from clean cases to dirty cases and different ones that have gotten reported. But they're doing things in the OR. Any case that's longer than 2 hours, they automatically do a glove change just because of the tentative holes in gloves and just everything, trying to maintain that consistency. They're warming patients. We have been for a couple of years. They warm them pre, during, and post. A lot of evidence in the research that supports different things to try to prevent infection. So I know surgical areas and post-op are really trying to focus on those kind of things. And then ventilator-acquired pneumonia. None of those in the last year, so that's good. Some of the process measures that we look at, elective inductions below 39 weeks, the obstetricians have worked very diligently with us on this. We do not electively induce any pregnant mom unless the mother is at risk, in severe issues, or the fetus is, but we've been doing very well with that over the last couple of years. Influenza vaccine and VTE measures, those are ones that it still kind of relies on some human intervention to make sure that we see that the flu vaccine hasn't been given before the patient goes home and we give it, and the CPOE orders, if they're in there for VTE prevention or not, and if not, we kind of have to jog the physicians. So if we miss one patient, it will drop us below 100%, so it doesn't take much to influence those two. Stroke measures have been at 100%, which is good. Our time to transfer for acute MIs, that's running well below 60, which is wonderful. And the area that we've had some difficulties with, the time to EKG for acute MIs and chest pain, first quarter 16 is probably the lowest we've been in a couple of years. When someone comes into the ER and they're very definite a chest pain, it's very easy to get that EKG done and get it done quickly. The ones that we were struggling with were those atypical presentations, people that came in with different signs that wouldn't necessarily lead you to think of chest pain right away. So what they've done is they've kind of expanded some of their protocols so that they're doing EKGs on a few more chief complaints that come into the ER to try to get that EKG time down. Now the squads can do EKGs on acute MIs en route, and we can count those too, so that does help to bring our numbers down. But that's one that we've been working on quite a bit and trying to identify where the gaps are in that. Time to bone fracture pain management, the ER docs have been working with us on the last two as well. That is trying to get pain med into a patient that comes in with a break, even before we get an x-ray maybe on them. So they've kind of done some protocols to help alleviate that patient's pain. It used to be that they kind of wanted an x-ray and know what it was before they'd medicate them, but we've kind of broadened those protocols as well. So we've been trying to bring that down. And then sepsis early management bundle, there's a series of 4 different items that go into this. Fluid, hydration, lactate levels, a couple of different things that the ER docs are trying to monitor. The inpatient areas also have a trigger tool. If the patient's condition changes, and a couple of different things that they monitor to trip the physician that we've had a change in some things, that this patient may be going down a sepsis pathway. The sooner you can catch sepsis, of course, the better the outcome is. So that's been something that's been in the research quite a bit. The mortality related to sepsis in hospitals is pretty high. So we've been working pretty diligently on that as well. Hand hygiene, you'll notice a little dip in the first quarter. Last year we did internal surveyors. So it was kind of your peers that were out there monitoring. This year we went back to an OHA surveyor, which is usually a nursing student that is unknown to everybody, and they come in once a month. And they're pretty diligent. They have a stopwatch on their clipboard or whatever they're carrying, and if you wash your hands with soap and water and you stop at 14 and a half seconds, you didn't get counted. It has to be at least 15 seconds that you're washing your hands. Or if you didn't gel in, gel out, you don't get counted. Now if she can't see you, that's something that she won't count you, but if she sees you and you miss those time things where you walk into a patient room and don't gel, that's an issue for us. So just anybody, if you walk into a patient room, it doesn't matter what you're doing, gel in, gel out, just kind of get in the habit, and that way it kind of prevents anything. The other thing that we've been noticing is that gloves, people go in or out with gloves on. As we know, gloves are not perfect, there can be holes and access in those, so you need to get gloves off, preferably before you leave the room, and then gel. If you have to carry something out, then you need to get rid of that, and then you need to be sure and wash your hands or gel after you get those gloves off, and as soon as possible. Because what you see is people will go in a room, then they'll go out with the gloves on and get a wheelchair, and they go back. It's like you think you're protected somehow with these gloves on. It kind of gives you a false sense. So those were a couple of the things that we found the last quarter. So of course the goal is 100%, and we have some room to get there. Service pillar. HCAHPS, which is mostly our inpatient ranking, and these are the always scores. Unless you get an always, it doesn't count. So the first quarter was actually on the uphill climb, which is nice. You see a lot of sawtooths there. The one thing that I've been glad to see is that every time it goes up a little higher. So to me, we are making some progress, even though we have some downhill slides as well. So first quarter was pretty good in all those areas. Hospital environment, that is anywhere from sound, cleanliness to heat and cool in the patient's rooms. Those are things that trip that. Pain management, communication with meds, discharge instructions, and somewhat care transitions. I know the nursing areas have been working very hard on. Pain management is something that the patients may expect to be pain-free, and that's probably not a realistic expectation. So we're trying to coach the staff we're trying to manage your pain so that you are able to do your activities of daily living, but you may not be pain-free. But part of that is kind of some coaching and educating, communication about meds and discharge instructions. It's hard enough, I think, for us sometimes to understand what we're being discharged on, let alone our 80-year-old patients, and they don't have a good handle on what their issue is medically, what the meds are for. So we're trying hard to at least teach them a couple of the side effects and the generalities of what the medications are for. And then discharge instructions, we send them this somewhat handwritten thing with all these meds circled, and then we actually now are giving them information straight out of the EMR with their hospital stay summary. So it has a lot of medical jargon that they get home and don't understand what's in there. So we're working really hard to try to get those scores up as well. The transition questions that are actually in those in the survey may not be what you think, but when we're talking to the patients and trying to make decisions on what they want to do when they leave the hospital, how well do we take their preferences into account? If they wanted to go home, did we do everything that we could to make sure that they get home and have the care that they need? Good understanding of managing my health. A lot of them may not even know they've got COPD or CHF and what it means to work with that healthcare issue, and then understand the purpose of taking meds. Those are tough ones to deal with. Press Ganey is more of we do look at it on the inpatient side, but it's more of our outpatient ranking system. The emergency department, we expected that to drop a little bit during that transition of moving into the new area. We saw some drop in the fourth quarter as they were getting prepared, and it's coming up now with the opening and working through the systems. And then the outpatients on the area, which is where most of you are in this, cardiology, PT, radiology, all those outpatient procedures, their raw scores are usually in the mid-90s. So if you're at 95.2, you could be at a 90% 1 month and drop by 0.1%, go to 95.1, and you've dropped to 50%. There's a very narrow margin the higher up you get on those raw scores. So outpatient areas are really working hard to try and figure out the consistency and make sure that those scores stay up. First Care, they've been moving their scores nicely in the right direction, and ambulatory surgery is kind of sawtoothing a little bit. We did recently, I believe last week, have our Press Ganey surveyor in, or guidance. And she gave them some tips of things that are kind of trending in the ambulatory surgery areas if they could impact would make a big difference. So we got some good feedback from her visit. Under the growth pillar, this is the new emergency center, which you've probably all been through by this point. Some of the open house pictures, I think we had between 700 and 1,000 people come through the open house. And then our admissions and patient days, for the first 3 months of this year, we have been probably 6 to 7% above our budgeted volume in the inpatient areas. We haven't seen that for quite some time. You can see the downhill trend started in 2011. Our average daily census is between where it was in 13 and 14. And our ED and outpatient registrations also are up. Now ED usually goes up 1% to 1.5%. We usually see that every year. But it's going up a little bit too the first quarter. Now whether that'll stay or not, it is always an if. Surgeries and deliveries, this is the first year that has gone up. 14 we saw some increase in our deliveries and kind of flat in surgery, but surgery went up from 15 to 16 too, so that's nice to see. And then the finance pillar, I will turn it over to Mr. James.
I always get to do the finance stuff, so we'll start with, this is the first quarter. And if you look up at the numbers, about 33% of our income this first quarter came from the inpatient world, just kind of reiterating what Diana was telling you, because if we've ended up the last couple of years about where 70% is outpatient and 30% is inpatient. So this will tell you that the inpatient world grew a little faster than the outpatient world during the past quarter. So we billed out $61.8 million and then immediately turned around and wrote off about $35 million, leaving us with about $27 million, and then we got about $2 million of additional dollars. Those additional dollars, the majority of those are the meaningful use dollars, and those are some of the ones that we're worried about, because meaningful use dollars are beginning to get to their end of their life, and it's, what are we going to replace those with going forward. So we collected $29 million, and how did we spend that? We spent $15 million in salaries and benefits, $12 million in supplies, services, and other things that are needed to take care of patients, and then a little under $2 million for those fixed things that we have. So we ended up with about $29 million, so we had a profit of $313,000. Now that's not a lot of money, but I want to say for the first quarter, you've got to remember that when we were getting the ED ready to go, there was a lot of extra labor that was going on during that quarter. So there were a lot of people that were working a lot of extra hours just to get that up and ready to go. So the fact that it ended up positive is really a good thing for us during that first quarter. As we started talking about what are some of the things that we want to talk to everybody about, one of the things we thought about was as we're changing our financial times, as we're beginning to look at different ways to get reimbursed, let's talk a little bit about population health. Does anybody have a good definition of population health? I'm looking for one because there's really not one out there. If you want to be really nice about it, you say population health is really kind of taking a group of responsibility for a group of people and looking at all of their healthcare needs and making sure that we're doing the best we can to make sure those people are healthy. If you want to be a little bit more cynical, you might say this is a way Medicare is looking at shifting some of the burden of who gets to pay for what and trying to save themselves some money. I'm going to go over a couple of ways that we're doing stuff. Medicare or CMS has not come up with a way that they really like to replace the current way that we're being reimbursed, but one of those ways is an accountable care organization. Now, Union joined an accountable care organization on January 1 of this year, and we had to go in with Altman and Pomerene to do it. You have to have a minimum of 10,000 lives. Between the Stark County lives, the Holmes County lives, and the Tuscarawas County lives, we have about 15,000. About 3,000 of those are assigned in Tuscarawas County. So we're in the Altman ACO, and we have 34, 36 measures that we have to meet. And these are the quality measures. And that's sort of one of the qualifiers that says, okay, you still got to meet all these quality metrics before you can actually begin to get some money. Now, how do you look at the money thing? Roughly, if you say those 15,000 lives spend about $10,000 each, if you actually want to know the number, it's $10,107. That's the amount of money that the average Medicare patient across those 15,000 people spent. Now, of course, some of those people spent a lot more, some spent none. But that includes all of their medications, all of their doctor's visits, their hospital stays, their nursing home stays, all of that stuff. So they're saying, okay, accountable care organization, you take care of those patients and you say how you're going to save it. Well, the first 2.7%, and that's another formula that CMS has, really all goes to Medicare, which if you do the math real quick, about $4 million there. You all of a sudden have to get to that $4 million before you can start sharing. Now, how you're going to share anything that you save over the $4 million has to be determined before you go to the federal government. So what we did is we said 70% of it's going to go to the doctors, 30% are going to go to the hospitals, 70% of the 70% is going to go to the primary care physicians, 30% is going to go to the specialty physicians. The 70% that's going to go to the primary care physicians will be divvied up because if you've got 100 patients and you've got 1,000 patients, you're going to get more because you're caring for 1,000 patients. You can't do that with the specialists because the specialists, how they may be making money is by not seeing you at all. They may say, an orthopedic surgeon may say, you're going to do just as well if I put you into therapy as if I do surgery on you. Now, in the old days, you want to do the surgery because it's what you get income off of, but now it's really what you have left over. So, okay, we're going to save all that money, and it has to be kind of divvied up with a specialist by everybody just gets a chunk of it. Now, this sounds really good. We know, we got a list of the 15,000 people that we had them at the beginning of 2015. We take care of them in 2016, and in 2017, we will figure out if those are the same 15,000 people or not. Because you may have started out in the Altman ACO and you may end up in the Summa ACO because you're attributed to them based on the fact of where you spend the money. So if you spend more money with a doc in a Summa system, you're going to get moved. Same thing here. If you were suddenly, we took care of a patient that was in Twin City and that was not part of our ACO at the beginning, and now they all of a sudden are attributed to us, we're now responsible for their care, although we didn't even know they were one of our patients when we started this. So it's kind of interesting. You've got to figure out a way to take care of people whether you don't know if they're in your system or not. So you basically are taking care of all of the Medicare patients the same way, and you determine the savings after the fact. Okay, that one's pretty fun. Let's look at another one. This is bundling, and bundling in orthopedics is probably one of the things that Secretary Burwell sat out there and said, I'm making more money from Medicare on this. Let's make this mandatory. So she waved her magic wand and said, I've seen it 63 major cities and I've seen it 67 major cities. But she said, okay, all of the hospitals in these major metropolitan areas are now going to be paid on a bundle. Now, an orthopedic bundle is you're responsible for the 30 days of care before the surgery, you're responsible for the surgery, and you're responsible for the 90 days of care after the surgery. So you hospital now have to figure out how to work that. The pre-hospital care is generally a fairly minor amount of money. The amount of money that is spent while you're in the hospital doesn't vary that much because we all get paid on DRGs. So it doesn't really matter what our consumption of cost inside is. It's really what they're paying, so that is pretty fixed. So most of the cost is in the post-acute care program. That's where you see most of the people in the country working on it. In Ohio, we love to put people in nursing homes. Compared to the other ACOs, we put them in about 40% more time. Now, you've probably seen some orthopedic patients. I have people I know in the community that they've told me where they're going for their post-acute care before they've ever had the surgery. If you go into a nursing home, it's costing 5 or 6 times more than if you go into home care. If you go into home care, it's costing you 3 or 4 times more than if you are able to get to the healthplex. So the goal now is to move people from the nursing home to health or to home care on. The ACOs, if you look at those, while we have a 40% higher use of nursing homes in Ohio, we have a 30% lower use of home care. So we now have been put in the middle of between the physicians and the hospital. We've been put in the middle with the patients to say, okay, we've got to figure out a reason or a need for you to do this. The reason I'm talking about this is I figure we've got 12 to 18 months before Secretary Burwell says we're going to move this out to everybody and all over the country. It's starting in orthopedics because orthopedics is the cleanest group to do it. It's following shortly behind in cardiac. For us here, that would probably be a CHF bundle. And then there are oncology bundles that are being trialed out there with some other places. This one has tended to figure out some ways to do some additional money, so you'll continue to see that coming. Now, it's not just the payers that are looking for different things. Employers are looking for different things as well. We get a lot of transparency in pricing and looking at quality data. I get questions all the time from business people going, why does it cost this much in one place and this much in another place? Why isn't it the same? Business owners think we should all get paid the same amount no matter where we're at. There was an article I read a couple of weeks ago and it was talking about 2 different states, and I think they were a New England state and a southern state, and they were talking about the differences in the prices, but they said it's not just state to state. They've said 90 miles apart, or 60 miles apart, excuse me, between Cleveland, Ohio and Canton, Ohio. And they used a mammography and said in Cleveland they get paid $538 for it. In Canton they get paid $138 for the same procedure. Remember, we're in the Canton market, so we get that pay rate. So businesses in this area are going, why are my people paying this much in Cleveland and this much in Canton? They don't understand that. They're looking to control their costs, but they're also looking to improve their workforce, health, and their productivity. I get a lot of complaints from business owners that say, it took my employee 3 days to get into one of your docks before they could come back to work. Now think about it. You know, if you're suddenly got somebody that you're working with and they're off for 3 days, somebody's making up that difference. They're doing the same thing out there. That's why there are some businesses in town that are looking at telehealth options. They're looking at having on-site docs. We've got one company in town couldn't find an answer they wanted for in this area, so they've hired a company in Kentucky to come manage their stuff. The businesses are pushing this a lot. The individuals are access. You know, how fast can I get in? Access, 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 and that's what they're looking for. A lot of millennials and the people on Medicare are beginning to get very used to using a tablet. There's a lot of places in the country that Medicare patients have been able to do their visit with their doc, particularly for a chronic condition, by their tablets. And you know why Medicare people are very comfortable in using their tablets for a doc visit? That's how they Skype their grandchildren. That's how they've become very adept at that. The consumerism piece goes up to the dollars. If I have to go to your friendly neighborhood hospital with high quality people and pay $1,000 for the MRI, but I can go to the strip mall and pay $350, I don't know that the doc reading that might not have the same credentials as the doctor at the hospital. I don't know that the tech has the same credentials as the hospital. All I know is it's $350. It's coming out of my pocket. Most of us are going to pick the $350 option. We're not going to pick the $1,000 option. So that's another piece that's sitting out there. What's Union doing specifically? We've got a model called direct primary care that's accessing primary care quickly. It's also agreeing to be in some of the protocols that are more likely to be wellness oriented. We're doing this with our own employees, but we're doing it because we are trying to we want to take this out and sell it to businesses because we know that's what they want. There's extended primary care team members. You probably have seen the end of the primary care doc by himself or by herself, because what you've got now is in that office you're going to have a nutritionist, you're going to have a pharmacist. They may not be there all the time, but you're going to have the social worker, behavioral medicine. You're going to have all of those other pieces involved in taking care of that person. One of the things that we are trying to do is move our business. If I'd been standing up here 15 years ago, I probably would have said we need more business. We need more patients in the beds. We need more outpatient business. And now we're going to a different payer system. Our payer system is changing from a transaction to here's a bunch of money, you take care of the people, and what you have left over you get to keep. So what you begin to do is you begin to look at those outpatient and particularly physicians' offices. I read an article once where somebody said 30% of all inpatient admissions are failures of the doctor's office to recognize that patient is sick in a timely manner. And think about that. All of a sudden, we 30% less patients. That's 1 out of every 3 patients we have. That also impacts our ED visits and that sort of thing. Care Coordination Center, in the past, if Rick came to me as a primary care physician and I said, okay, Rick, you need to go see a specialist, Rick walked out the door and it was really his problem to go get that appointment with a specialist. Guess what? Now I'm responsible for how much Rick is going to cost me. If he doesn't get that appointment in a timely manner and some things happen and he ends up going to the emergency room in the hospital, that's going to cost me money. So before he leaves that office, I'm coordinating where he is going to be on that, when he's going to have that plan, and I'm also going to be following up with him. If I have a patient that has diabetes and they're not managing it real well, I'm going to have someone in my office calling and checking on them on a regular basis because I'm now responsible for the dollars taking care of that person. So that's changing that. Data analytics and data warehousing, we're analyzing everybody in Tuscarawas County. Part of that community needs assessment is part of this, but as we take everybody's health information data and begin to analyze it, we want to determine what are the diseases, what are the trends, what are the things that are going on in our community that we need to manage to make sure we keep you healthy, or if you're going to have some sort of disease, we can get you healthy or managing as well as you can do it. So that's the name of the game going forward, is really just doing the analyticals on this. And the traditional transitional care focus, Diana talked a little bit about that, but that's when we do the handoffs. How do we transition someone from one level of care to another level of care, whether it's going up the scale or down the scale? And we have to look at those very carefully to make sure we're doing it. And we've got some great things that are going on there with people going into homes and doing some other stuff. The people pillar. This is one of the things I'm very excited about. Those engagement surveys that we do every year, and we've done them with the advisory board for a number of years now. Well, because we've gotten such high scores for several years consistently, the advisory board named Union Hospital their 2016 Workplace of the Year. So you'll be hearing a little bit more of this. We're going to be celebrating this. We just literally found out about this last week, right as we were putting these together at the last minute. So we're going to celebrate this in a few weeks. We had one retirement during the quarter, Les McGrath. I think he was here 16 years. He retired. The auxiliary generally gives us a check every year. This year it was for $203,000. We appreciate all the work that these ladies and gentlemen do in trying to raise money for us. One of the things they had during the first quarter was the Chocolate Love Affair. They had a couple of events in April as well. And in the community, UH Tech, some of you may recognize this area. We have reached out to a lot of students in the Tuscarawas County area for a number of years now. We hear back from a lot of these either students or parents about how well this program is done and how it has changed someone's life in the sense of they've decided something that they wanted to do or a profession that they've chosen. So those are kind of nice. So in summary, union's been recognized for quality and employee engagement. We fell to a B in the leapfrog for patient safety, so we want to get back up to that A. Our patient experience data was much better in the first quarter than it had been in the fourth quarter. Our first quarter volumes were high, particularly in the inpatient area. And population health is bringing us new ways to be paid. Are there any questions?